Speaker will be Dr. Bruce Lytle, talking about the small annulus and biological valves myectomy. As many of you know, Dr. Lytle was the PI for the Edwards 2700 valve that was started in 1983, and back in 1986 he taught me how to do myectomies. Thank you very much, Bruce.
So good morning. So I have nothing to disclose. All of the strategies and techniques we are going to talk about are actually legal to use in America, and they have been carried out on patients that are alive at the time that the operation is done. So I think that, let's see, there we go. The reason that people die after they have an aortic valve replacement is basically these three reasons. They have issues with one or another of the coronaries, they have bleeding from someplace, or they have bad myocardial protection. And these strategies are designed to prevent those things from occurring. Now, this is a diagram, a picture, and so for most of the time, and we are not going to be talking about tunnel stenoses or congenital abnormalities, we're going to be talking about enlarging the aortic root in the most common situation where there's some logic associated with doing that, which is usually an older person without a bicuspid aortic valve, often an older woman. And the strategy here is, this is the juncture of the aortic and the mitral valve, is the enlargement is done at that level right there. And basically what we're going to do is we're going to make an incision down to the depth of the non-coronary cusp where we just pointed out. We're going to extend it into the mitral valve, not to injure the mitral valve or to have to patch the mitral valve, but to open that. We're going to enlarge the aortic root with a teardrop-shaped patch of biologic tissue. For a primary operation, it's almost always native pericardium. We're going to adjust the valve so the patch forms part of the annulus, and then we're going to not close the entire aorta with the patch. So here is the situation we're looking at under most circumstances, particularly if this is a primary operation. Once we begin to make the incision, this is what we see. We have a stenotic aortic valve. The incision is carried down really pretty much to the middle of the non-coronary cusp. If we're going to make an error, we'd rather go farther left than farther right. And once we've excised the valve, then we're going to size things and take a look and see whether we think that it is necessary to enlarge the area that we're going to put the valve in. Remember, when we're putting a valve in, what we're trying to do is make a hole bigger. We're trying to put a bigger hole in an area where a smaller hole was. I'm not yet aware of any of these valves that actually accelerate the blood flow through them. All of them have some level of impedance, and it really is a question of trying to make the hole bigger. So that incision is carried down usually a few millimeters into the mitral valve, and once that's accomplished, then we're going to reconstruct that. Now, they have asked me to talk about performing a myectomy in this setting. And the first thing that I would say is that particularly in this group of patients, which are often older women, they don't have bicuspid valves, they have aortic stenosis. If they have preoperative anterior motion of the mitral valve, then that's a good reason to do a formal myectomy. If they don't have preoperative anterior motion of the mitral valve, that's not a good reason to do a formal myectomy, and you end up putting yourself at some risk. One of the reasons that we get away with doing myectomies with an extremely low risk for people that have hypertrophic cardiomyopathy is the character of the muscle is different in patients with hypertrophic cardiomyopathy. In older people that may just have some ventricular hypertrophy, doing a formal myectomy like we would do in the phase of where we're doing a myectomy for SAM is a very good way to get into trouble, either to create a ventricular septal rupture or to have a hematoma necessitate out the lateral wall of the heart. So my advice is that be very careful when doing a myectomy for someone that you have not demonstrated SAM beforehand. Now, this is the anatomy that we are going to be looking at if we create a myectomy. One of the things we want to watch out for is the conduction system. These, in the books you read about these kinds of myectomies, you would call it, this is, with respect to Dr. Morrow, probably a channel that was described as the Morrow operation. This is what people look at as an extended myectomy. This probably is not enough. And this probably creates the risk of too many complications, in my judgment. And so the myectomy that we usually do looks something more like this. It starts out, it's a trapezoid, basically. The depth on the septum is calculated by the septal thickness preoperatively. The normal septal thickness, the upper limits of normal is 13 millimeters. That's what we're usually shooting for. And so we want to start out with a narrower myectomy to avoid the conduction system, which is right about here. We will always end up with a left bundle. We want to extend it down past the heads of the papillary muscles. And we have a bunch of special instruments that we use to do that, and you can create those instruments by taking a coker clamp and bending the knife handles. And this is the type of a myectomy that's carried out. That's what we end up with. So once we've done that, if the patient really needs it, then we end up with sewing this teardrop shaped patch in place. And this can be a 4-0 or a 5-0. This is very broad. You can see that it opens the aorta. And we are going to put this, my fault. We're going to, once the base is sewn in place, then we're going to put the valve in place. Now, it is very important to be conscious of the left coronary artery. Most of the time, we use one of the varieties of the Edwards valve because the Edwards valve does not have a rail that extends up here, which a lot of the other valves do. Now, there are many other valves that have been created that also don't have that rail now, but none of them really have been followed up for very long. We'll see what happens. But any type of valve can be placed in here. And as we see, we go inside out on this pericardial patch that we've put in there, and that becomes part of the annulus. So if we look at it from the outside, this is kind of what we end up with. Now, this is normally we'll put a piece of Teflon felt that these sutures go through, and we haven't done this here for the purpose of illustration. And so the aortotomy is closed. Now, be careful about closing the entire aortotomy with a patch, because I think what I've seen a couple times, once in one of my patients and once in one of my colleagues, is that when we open the aorta like that, the aorta goes like that. And I think that the right coronary artery can kink. Now, it doesn't happen very often, but I think it happens. And so we tend not to close the entire aortotomy with this patch, but just bring it up about halfway and then primarily close it to prevent that section of the aorta from falling back and kinking the right coronary artery. This is something that is extremely reliable. It can be done hundreds of times with control over the complications and control over those bad things that we talked about, which is the coronary arteries and bleeding. Thank you very much.